This is information on how to hide your money in secret Canadian bank accounts. We ain't talking about that today. Welcome to cardio number 1. Okay, I'm big on sequence of pathologies, and in cardiology, sequence of pathologies is really kind of an important concept. So let's just actually start this talk by getting your brain more used to thinking about how one pathologic circumstance segues into another. Over on the far side of this slide here, I have things such as hypertension, hyperlipidemia, diabetes. And then I've got the little leads to arrow. And then I've got atherogenesis, which we're going to talk about. Super important inflammatory process. Atherogenesis then leads to what's right next to me here. Coronary artery disease, strokes, peripheral vascular disease, and all kinds of other stuff. Here's how I might lay out a sequence of pathologies, not necessarily the way you might do it, but it's the way my brain thinks about how one thing leads to another, leads to another, leads to another, leads to another, leads to another. So the first up in our pathologies today is this whole thing called hyperlipidemia. Hyper meaning too much, emia meaning blood, and lipids meaning fat. Too much fat in the blood. Now, for this to make sense, you gotta know a couple things. First of all, we make our own cholesterol for the phospholipid bilayer that our cells are made of. So if we make it, there's a pretty good argument that we kind of don't need cholesterol in our diets. The other kind of background bit of information you need to know is the job of cholesterol transportation from liver to target tissue and back again. There are carrier lipoproteins that bring cholesterol to where it's needed and then bring it back to the liver again. Low density lipoproteins are the ones that go to the liver, bring cholesterol out, and give it to the whatever tissues and cells are requiring it. High-density lipoproteins, HDLs, do the opposite. They take excess cholesterol from the blood and bring it back to its storage area in the liver. Patients who have hyperlipidemia, and another term that I think is actually more appropriate is dyslipidemia. The hyperlipidemia really means too much LDL in the blood, bringing too much cholesterol out into the bloodstream, more than is necessary to build and manufacture new cells. And a lot of people think this is just a byproduct of a diet that overloads our systems with cholesterol, such that this is kind of a natural response to what we are eating. If you ever heard anyone say LDL is the bad cholesterol and HDL is good cholesterol, what they're referring to is the job. LDL brings cholesterol out to the blood in hopes that it gets utilized for making new cells. LDL removes it from the blood and puts it back where its storage place is, to the liver. So, logically, high LDL levels in a person's blood indicate that they are bringing cholesterol out of the liver in hopes that it will be used to make new cells. So LDL and HDL have two differing jobs, and a lipid profile looks at both of them in addition to total cholesterol. This is something you'll be looking at with your patients for years and years to come. Not only how much total cholesterol do they have in their blood, but how many of the transport proteins, lipoproteins specifically, do they have as well. The higher the LDL, the more cholesterol is being transported out of the liver. Now, the lower the HDL, That signifies that not enough cholesterol is being taken back to the liver. Now, just garden variety hyperlipidemia isn't really something your patients can feel. This is why it's a routine part of blood work to have those done or run on a yearly basis. I have them done every year at my primary care physician's office. I can't feel what my blood cholesterol level is. So hyperlipidemia is kind of a sneaky thing, and it can cause problems in a pathologically silent way, much like hypertension, which we'll get to in just a second. Before we get there, though, I do want to mention a little bit about a condition called familial hypercholesterolemia. This is a genetic defect in catabolism of low-density lipoproteins. This is a real problem. It's actually the most common autosomal dominant disease out there. So yeah, you probably will see it. Patients with familial hypercholesterolemia have markedly elevated LDL levels, much higher than the usual amount seen in people who just have bad diets. They also typically start showing dyslipidemic characteristics at an earlier age than you normally see those things. One thing that I think is particularly interesting about familial hypercholesterolemia is the gene dose idea. There's basically 3 genes that control catabolism of low-density lipoproteins. And patients with familial hypercholesterolemia can be a number of combinations between homozygous and heterozygous for mutations to any of those 3 genes. Now, if they happen to have a mutation to more than one gene, or are homozygously mutated on a particular gene, that's a higher severity level than a patient who is just simply heterozygous for one mutation out of the 6 alleles. And that gets into genetic dose. And the interesting thing is that it translates over into how severe their familial hypercholesterolemia is. Hypertension pathology is simple and complicated. First of all, it has 2 basic divisions to it, primary and secondary. And here's the weird thing. In primary hypertension, we don't specifically know what the underlying pathospecifics are. Isn't that nice? That'll make for an easy test question. In secondary hypertension, we do. The blood pressure is high due to something we can identify. Maybe it's kidney disease and a disruption to the renin-angiotensin-aldosterone system. So if you look across the top of this slide, things such as excess sodium intake, kidney disease, stress, genetics, obesity, and factors specific to the endothelial lining of our blood vessels can all play into the development of hypertension. If you really think about it, primary hypertension is probably just numerous factors playing into elevations in blood pressure, and we're unable to clearly identify all of them. Let me give you a more concrete example. If excess sodium intake were the single factor creating hypertension in individuals, then all of us would be hypertensive all the time. That's not the case. However, in terms of intervention, lowering salt intake is always recommended. So as you read through the pink boxes, which are potential sources of blood pressure dysfunction, the yellow row is their consequence, their sequela. Then further down, the kind of greenish rectangles are meant to show you exactly what's going on with regards to fluid valence. And then the blue row at the bottom is more specific with regard to what the end result is in terms of affecting 2 things, cardiac output and peripheral resistance. These two variables then factor in to give us normal versus excessive blood pressure. So while most cases of hypertension are primary and we do not specifically know what combination of pathologic events is contributing to the blood pressure elevation, what we do know and have well researched is a whole host of risk factors: age, diabetes status, tobacco use, alcohol use. When I think of these risk factors, I like to think of pie charts. And each one of these risk factors contributes a certain percentage to the development of hypertension. Do I have exact percentages for you for each of the bullet points here? No, I don't. But the way I think about it is, well, maybe stress kind of contributes 10% of the picture with regards to the development of hypertension. And that's not very much, considering that excess sodium in the diet probably contributes 75% to the development of hypertension. So I tend to think of risk factors in a lot of different pathologies with this kind of pie chart mentality, where they're all contributing to the pathology, but they're contributing to it in different percentages. So just imagine you're a primary care nurse, you're in the clinic, new patient coming in. Is that patient going to tell you they have high blood pressure if they've never been diagnosed with it before? Are you going to know they have high blood pressure if they've never been diagnosed with it before? Probably not. Hypertension, like hyperlipidemia, rarely symptomatic. And that's why we take blood pressure all the time with our healthcare visits. Some people may have headaches. Some may tell you that their vision will get a little blurry or changed when their blood pressure's up. More often than not, they're not going to have any symptoms at all. The longer blood pressure stays elevated and the longer the heart has to push against high blood pressure, the more likely that there will be changes to the heart that may impact the point of maximal impulse. That's the PMI. That's where you're palpating on the chest wall. A heart that is sick from long-term hypertension will sometimes enlarge and it will displace the PMI laterally. In addition, if the heart is having to work against higher pressures and perhaps having higher volume and pressure within the heart itself, those changes can cause extra heart sounds. So rather than just hearing an S1, S2, which are indicative of valves closing, you can also hear the sounds of turbulent blood within the heart. And the one that would be most common in a patient with uncontrolled hypertension is an S4 sound. That's a soft sound that occurs just before S1 in the cardiac cycle. Let me see if I can get some audio playing of an S4. Now, the numbers and their limits get revised every couple years by the American College of Cardiology and the American Heart Association. For purposes of our class, you don't have to memorize every kind of interval and stage, but you do have to know that 120 over 80 is the boundary between normal and high blood pressure. I say this because your patients will think that 120 over 80 is kind of a midpoint and you've got wiggle room. Little higher, little lower, it's all around normal. Yeah, Ixnay on the midpoint day. 120 over 80 is the boundary between high blood pressure and normal blood pressure. And I almost always mention to students the idea of low blood pressure. And this is a point of education for your patients too. Patients will say, well, I don't want my blood pressure to get too low. That's rarely a concern. And the clinical scenario is the nurse who takes the patient's blood pressure and it's 95/50. And they feel great. But they look at the number and they go, oh, my blood pressure's too low. And maybe even some nurses will go, that blood pressure is too low. And then I ask, are they symptomatic? At 95/55, are they lightheaded, dizzy, feeling like they're going to pass out? Showing me clinically that in some way they're not pushing blood properly up into their brain? If the answer is no, then there isn't a problem. The nickname for hypertension is the silent killer because people can't feel their blood pressure be up for the most part, yet it's doing damage. It's doing damage to the vascular endothelium. It's eliciting an inflammatory process, and slowly over the course of years, it is causing vascular damage all over the body. This is most significant in areas such as the central nervous system, where it can cause a cerebrovascular accident. In the coronary arteries, where atherosclerosis can then lead to plaque formations and heart attacks. In the kidneys, where the high blood pressures can tear up the nephrons. In clinical practice, you will hear the term occasionally hypertensive crisis or hypertensive emergency. This is a patient whose blood pressure is so high that they risk acutely injuring the brain or their vision or their heart or some end organ, some target organ that's sensitive to extremely high blood pressures.